No problem.
Okay, everyone. We are moving on to the next section. So I have the pleasure of introducing someone who is very special to me. Mary Pagani has been an integral part in connecting community partners, including myself, to formulate extremely strong associations, teams, and individuals. Mary is the manager of programs, partnerships, and operations with the Peel Addiction Assessment and Referral Center. Mary has worked with PARC for 17 years and has been an active HSJCC committee member for the past 5 years, with the most recent participation in the role of co-chair. Mary has been instrumental in the development, implementation, and operations of the Brampton Drug Treatment Court. She recognizes the value of partnership and as such has made significant efforts to bring community stakeholders together. Her contributions to the addictions and mental health sector has positively affected those who are impacted by substance use and or mental illness. So Mary, it is all you.
Well, thank you so much, Erin, for that very warm welcome and for bringing us to this part of the agenda. As mentioned, my name is Mary Pagani, and I have the distinct pleasure of moderating this panel to discuss the very important and critical topic of the opioid crisis. Today, our esteemed panelists will address the opioid crisis and the implications for the criminal justice system, law enforcement, and treatment. I am joined today by three very well-respected and incredibly knowledgeable professionals who will share their perspectives and their experiences as it relates to the opioid crisis. I'll introduce each panelist before they each present, and I'll ask that we hold down questions until after all three presenters have had an opportunity to present to us. So without further ado, I'm going to move us along and I'm going to introduce to you our first presenter, and that is Dr. Allie Damji. Dr. Allie Damji is an academic family physician, an addiction medicine curriculum lead, quality initiatives program director, and COVID-19 director at Credit Valley Family Health Team in his hometown of Mississauga. He additionally specializes in addiction medicine and practices at the Halton and Mississauga RAM Clinic, and he regularly teaches medical students and resident doctors on the topic of addiction medicine at the University of Toronto. During the pandemic, Dr. Damji became Trillium Health Partners physician lead for the COVID-19 assessment centers and a clinical lead for the mass vaccination centers. He is the newest elected member of the Professional Staff Association Executive. He is an assistant professor at the University of Toronto Department of Family and Community Medicine and investigator at the Institute for Better Health. He is actively involved in the leadership of many areas of our healthcare system, including as a member of the Ontario Health Central Region Mental Health and Addictions Advisory Table. And he was recently honored with the College of Family Physicians of Canada Award of Excellence, Mississauga Academy of Medicine Clerkship Teaching Award, and the COVID Hero Award from the City of Mississauga. Driven by his family's history as new immigrants and refugees, he is deeply passionate about improving health equity. So thank you so much, and I will move it over to you, Dr. Damji.
Thank you so much for the kind introduction, Mary, and for the opportunity to present today. I'm just going to share my screen, and I'll just confirm that it's working before I start. Okay, is it still up? Yeah, okay, perfect. So thank you again to everyone for having me here today. And I'll be kicking things off by speaking about the opioid crisis, and specifically from the medical perspective, how did we get here and what are we going to do about it now? In terms of a little bit about me, you've heard that really kind introduction from Mary. But I wanted to speak a little bit around how I became involved in this field of addiction medicine. And really, like I'm sure is the case for so many of us here at this virtual table today, it's really something that you fall into in many ways. And so for me, there's some photos there from my time when I was a medical student where I decided one day to volunteer with distributing safe supplies around the city of Toronto. And so we were in that gigantic van from Toronto Public Health, and we're going around and meeting patients and clients who use substances where they were and providing them with safe supplies. And I remember However, that left such a huge impression on me as a medical student and made me think around wanting to do more. And then the other photos that I have here are actually from up north, from remote parts of Northern Ontario. When I was a family practice resident, in my final year, I traveled up north to Sioux Lookout, and I spent some time in some of the remote communities that were fly-in communities around that area. And these included regions such as Cat Lake, as well as Sandy Lake. And these are some photos from that area. And I recall one of the presenters was mentioning the rates of poverty in those communities. And as you can see, certainly the conditions in these areas are quite unfortunate. You can see that there's a lack of roads and infrastructure in these places, and there were high prevalence rates of addiction. And part of my talk today is going to be around looking back at those social determinants of health that were mentioned this morning. Now, also, I think it's important for us to recognize what our patients encounter in our health system. And so these can be common things that they can hear from even medical professionals and health professionals, being called drug seekers, being called problem patients. And, you know, these are the patients you don't want to take on into your practice because they're going to be problematic and cause difficulties. You know, this goes back to that trauma-informed care and some of the practices that we have in place, some of the rules that we have in place in our practices and communities. And these can be quite traumatizing to our patients. They can be labeled as addicts or junkies, or told that there isn't much that the healthcare system in its traditional way can provide to them, and often, you know, are shown the door. And this can be the very sad, real reality that's lived by our patients. And I certainly hear that even in this day and age at my RAM clinic. And so it's important that when we think about addiction, we think about it in a very holistic way. And that's one of the areas that I'm quite passionate about. And when we think about addiction, it's important that we move beyond what we may have been socialized to think in the past. You know, for example, you know, there was a time where people were told that addiction only happened to bad people, or that it was some sort of moral failing, or if someone wasn't religious, that meant that they would develop an addiction. And we certainly know now that isn't the case. And I'm next going to speak a little bit about that. So this here is the dopaminergic pathway in the brain. And dopamine is one of the neurotransmitters in our brain that's very crucial to memory formation, but it also helps us to remember experiences that are both positive and negative. And so if you get a good sensation or a good memory from something, that will essentially activate this pathway. And so this is the part of our brain that essentially experiences reward. And reward can come from a variety of different things. Let's say, for example, if you really enjoy video games or you really enjoy exercise, that may very well activate that dopamine pathway and make you feel good and want you to have more of the stimulus. However, what happens in the case of addiction is that this pathway gets hijacked by that substance. And so let's say if the substance is an opioid, the opioid is going to activate that dopamine pathway. It's going to potentially make someone feel well, and so they're going to want to use the substance again. But what happens over time is that the receptors will actually start to upregulate. So what that means is now you have more receptors, but if you're using the same amount of the drug, it's not going to activate all of those receptors like it was before. And so that's how tolerance develops. And that's why people then need to use more of the substance to get the same effect. However, it's not all about just receiving a high from that particular substance. And we know that now in this newer model of understanding addiction. So that dopaminergic pathway is part of the picture. And in this diagram, that's referring to the basal ganglia. And I'll label things as I go. So hopefully you can see my pointer. So the basal ganglia is where we get that dopaminergic pathway that I was just describing. And that's that feel-good sensation that comes from the substance. However, there are also other parts of the brain that are involved. So our prefrontal cortex is the front part of the brain, and that's what's responsible for executive function, so allowing us to make decisions. When someone uses substances, what ends up happening is that this part of the brain becomes very preoccupied with the substance. It becomes hijacked again by that substance, and all that someone can think about is that substance, and their life starts to revolve around the anticipation and the behaviors around trying to obtain that substance. And that's why that's part of the diagnostic criteria that we use, because people become very preoccupied with that substance. And that's actually an effect on the prefrontal cortex of the brain. And then this last part here, the extended amygdala, is something I really want to pay special attention to, because it goes back to what we were talking about earlier with the impact of trauma, with the impact of mental health, and what that does to someone. And so there's a new phenomenon that we're describing in the field of addiction medicine called hyperkatifia. And what hyperkatifia refers to is an enhanced feeling of negative emotions. So the things that are making people upset, the things that, traumatize people, the childhood trauma that they may have had, the psychiatric comorbidities that they have, the genetic factors and the environment that they're in, those all may contribute to negative emotions. And what the substance is actually doing is it's suppressing that hyperkatifia. But what happens in the long term is that the substance actually starts to make their perception of these things even worse. And so they start to experience withdrawal when they don't use the substance. And a lot of that trauma, a lot of those psychiatric comorbidities, they flare up when they stop using the substance. And that's why, for many of us who work in the field of addiction medicine, when you see your patients, they're not seeing you because they're getting a rush or a high from the substance anymore. Instead, what they're experiencing day in and day out is an absolute misery if they're not using the substance, and they're trying to escape that constantly. And really, that's stemming from this hyperkatifia and the extended amygdala. So I think that framing is really important, because really addiction is a disease of despair. It's not a disease that is caused because people are getting highs off of substances. It's a disease of despair, and they're trying to make all of this negative stuff that they're experiencing go away. And the science is certainly backing that up. Now, in terms of the 4 C's of addiction medicine that we use in terms of making diagnosis, addiction is characterized by a loss of control over the use of a substance, compulsion to use the substance, meaning that they can't really control themselves, and all of a sudden, if they start using a little bit, it turns into a lot very quickly. Use despite consequences, so despite the negative consequences, whether they've been legal consequences, as we've discussed today, whether they've been personal consequences, social consequences, the use continues despite that. And cravings is the other C of addiction medicine. Now, you may be wondering, well, what makes a drug addictive? Why is it that only some things cause addiction and others don't? And that really relates to 2 concepts: pharmacodynamics, which is what the drug does to the body, and pharmacokinetics, what the body does to the drug. So pharmacodynamics will refer to things like whether a drug is a full agonist or if it's a partial agonist, and what exactly it does at that receptor in the brain. And a pharmacokinetic aspect is things like rate of the absorption of the drug. How quickly does the body eliminate the drug from the body and process it? And how long does it take for it to metabolize the drug? These are different things that will affect whether or not a drug is addictive. Some other factors that may play a role also are things like the lipophilicity of the blood, and that refers to whether or not it can pass through fat. And the reason why that's important is that the blood-brain barrier will have a predominance for certain substances that can cross that blood-brain barrier. And so again, that's an element of a substance that might make it more addictive. It's important too to think about things like how long-acting or short-acting a substance is, which again gets back to those pharmacodynamics, and that will indicate whether or not an opioid is addictive. So for example, methadone, which I'll talk about as a treatment for patients suffering from opioid use disorder, has a very, very long half-life, and it doesn't cause a typical peak and trough. So when it's processed by the body, it's not going to give someone a rush and then a crash. It's going to just keep things level so their withdrawal is maintained. So that's an example of that concept there. I know you've seen this slide already, but I wanted to show it again, which is, the importance of the social determinants of health and how much these other factors contribute to someone's experience of illness. And remember, addiction is an illness. It's a medical condition. And certainly these social determinants play a huge role in whether or not someone suffers from addiction and how well they do in terms of their treatments. And to maybe provide a more local example, it was mentioned that I'm from Mississauga, and so certainly I'm quite passionate about my hometown. And I wanted to show some of the changes that have happened in our region in a very short amount of time. So this is Peel Region in 1980, and this is essentially showing rates of income levels across different neighborhoods here. So the areas that are kind of this yellow color are middle income. The areas that are blue are high, or dark blue are very high. And the areas that are brown are low or very low. And you'll see the change. So this is 1980. This is 2001. And this is 2016. So as you can see, the demographics and the socioeconomic status of our population has changed dramatically. But what myself and other clinicians practicing in the area will tell you is that the provision of services hasn't kept pace with what we're seeing there. And certainly when we think about things like the COVID-19 pandemic and which areas of Peel were most highly affected, you can also see a predominance and a correlation there in terms of the areas that are suffering in poverty. And the same is true for addiction. Certainly we do see addiction across the continuum, and I see patients of every income level coming through my doors. But I definitely do see a predominance amongst those who are in lower socioeconomic status. And certainly the patients who perhaps may never seek treatment are going to be represented in those groups because they simply can't access the treatments that are available. Now, the other part of today is talking about how we actually got here, and specifically here, meaning the opioid crisis. And so I wanted to first show this diagram, which shows 3 different ways of the opioid crisis and overdose deaths. And so I'm first going to talk about wave 1, which was the rise in prescription opioid overdose deaths that started in 1999. Now, how did this even happen in the first place? And we're all probably wondering this now, looking back, 20 to 21 years ago, as to how we could have believed that these drugs were safe. And it's incredible when you look back and look through the literature, just how dangerous some of the practices were and how we relied on evidence that really wasn't there. So this is a really famous 1980 letter. It's not even a journal article. It was in a peer-reviewed journal that was just a small little paragraph there. And you'll see in this letter, it says the following, that recently we examined our current files to determine the incidence of narcotic addiction in 39,946 hospitalized medical patients who were monitored consecutively. And although there were about 12,000 patients who received at least 1 narcotic preparation, there were only 4 cases of reasonably well-documented addiction in patients who had no history of addiction. The addiction was considered major in only 1 instance. The drugs implicated were meperidine in 2 patients, Percodan in 1, and hydromorphone in 1. We therefore conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. Now, all of us who practice evidence-based medicine would say a tiny paragraph like this should not be used to justify prescribing practices across multiple countries. But the sad reality is that's what happened. And what this diagram shows, and this comes from research that was done retroactively by colleagues at the University of Toronto, is it shows the degree to which that particular letter was cited. And the dark green areas are affirmational, meaning that this particular letter was cited in a way to confirm that the opioids were not addictive. And the ones that are in the other color here are negational, meaning that they were told to show that they used this article to show that opioids actually are addictive and that this was an unsafe way to promote these drugs. And as you can see, there was a huge spike in terms of this one article being cited over and over and over and over again. And really, article is an overstatement. Really, it's just a tiny little letter to the editor. But you can see how much this was cited over time. And you can see how this correlates in that time that we started to see an increased wave of prescription opioids and overdose deaths. On top of that, though, it wasn't just the fault of this one article. And the physicians involved with it were well-meaning people. They were just trying to publish an article in a journal. But there were other things that happened in our system more broadly that led to overprescribing of the opioids. And these included a few different things. So one of them, for example, was the fact that pain was identified as the 5th vital sign. And we had societies like the American Pain Society saying that if you were under-treating pain, that you were a bad doctor. The Joint Commission released a recommendation that said that opioids were safe and that we should use pain scales. And in fact, some hospitals went as far as creating patient experience surveys, and they tied compensation to that. So as a physician, if you were not liked by your patients, and liked in this case meant prescribing narcotics to them if they were experiencing pain, that you were a bad doctor, and therefore you would make less money by being penalized by your hospital. And in fact, there were even successful litigation cases against physicians for under-treating pain. So as a consequence, the profession started to lean towards prescribing these opioids quite liberally. And then when you have evidence coming from journals, or specifically one letter, but it looks as though multiple journals are saying that opioids are safe, but they're all quoting the same letter from 1980, you end up with a prescription opioid crisis like this, and you end up with overprescription of these drugs. We did realize that was a mistake, but we started to see large rates of opioid deaths, and we started to also see rates of opioid use disorder significantly climb during that time. And so post-2010, countries like Canada did the following. They delisted slow-release oxycodone from provincial formularies. So the reason for that was that OxyContin was actually being abused. It was a slow-release formulation that could be crushed and injected. And so the federal government decided to delist that particular drug to try and curb some of what was happening. They introduced and strengthened prescription monitoring programs across the province. There was enhanced prescriber education. And there was select disciplinary action against people who were deemed to be overprescribers of opioids. And then there was the introduction of restrictive opioid prescribing guidelines, which happened in 2016, 2017. And public awareness campaigns, of course, around the harms related to opioid use. But one of the things that was mentioned today, which I think was a very apt statement, is that sometimes when we do something, we don't always appreciate the next phase or the next reaction that will happen. And as you can see here, once those measures were implemented around that 2010 era, you start to see the commonly prescribed opioids go down, and you start to see the rates of prescription opioids decrease. However, you then also see that there was a rise in heroin overdose deaths that started in 2010. And that is likely related to the fact that people became very scared of prescribing opioids. They thought that the college was going to come down on them. And so physicians started to cut people off. There wasn't really great guidance provided on how to taper people off of opioids safely. Really, in terms of treatment options, it wasn't very widely known or available or accessible. And so patients were left to their own devices. And unfortunately, they turned to the street. And then as we introduce more restrictive prescription guidelines as well around the narcotics and having, lower dose regimens for patients on existing opioids, again, people may have started to turn to the street and started to seek other synthetic opioids and stronger opioids. And now we're facing a crisis of the other synthetic opioids like fentanyl, which has certainly outpaced heroin. And now we're seeing more and more patients using stronger opioids. And along with that, a higher rate of overdose deaths because of that. And so in the current state, 1 in 8 Canadians has an opioid prescription. And again, when we look at fentanyl compared to morphine, that's something that's 100 times stronger than morphine. So we're seeing people on much stronger doses and much stronger strength opioids currently. And as I said, 1 in 8 Canadians has an opioid prescription currently from their doctor. And in Ontario, at least 1 in 7 people have filled an opioid prescription. And this translates to about 2 million prescriptions a year. To 9 million prescriptions a year and 2 million people who have filled those prescriptions, so even higher than that. In terms of the COVID impact, we've seen the opioid overdose crisis dramatically worsen during the pandemic, with overdose deaths in Ontario increasing by 75% during the pandemic. And this is very recent data that's collected federally, which shows about 23,000 apparent opioid toxicity deaths between January 2016 and March 2021. The majority of deaths have occurred in British Columbia, Alberta, and Ontario. Most apparent opioid toxicity deaths are amongst males and individuals aged 20 to 49, and fentanyl analogs continue to be the major drivers of the crisis. And in addition, while certainly prescription opioids may have been that first wave, we're now seeing that 90% of accidental apparent opioid toxicity deaths from January to March 2021 involved a non-pharmaceutical opioid, meaning street opioids. So now we're dealing with a very, very different reality than what we were dealing with before, when it was the heroin crisis as a consequence of deprescribing. In addition, we have to keep in mind that the circumstances are changing even more. And so what this diagram shows is it's showing numbers of deaths. But what concerns me here and what keeps me up at night is the fact that we're also starting to see increasing deaths from non-opioids. So we're seeing increasing deaths from cocaine, for example, as well as psychostimulants with abuse potential. And what we're seeing on the ground here is that these substances are becoming contaminated. So when patients are buying cocaine off the street, they're dying from a fentanyl overdose because these patients have never had opioids before. And what they thought was cocaine actually was contaminated with fentanyl, and they end up dying from this. And we're certainly seeing higher and higher rates of that in terms of contamination of the drug supply. And that's why there is more and more energy being given and more support being given towards decriminalization of substances and potentially creating safe supply programs and opportunities for that, because we're recognizing that the drug supply has become toxic and that it's killing patients across the country. So how do we diagnose and treat addiction? And this will be the last part of my remarks today. So the DSM-5 criteria for opioid use disorder are listed here. I won't go through all of them to spare you that, but we do use evidence-based criteria in order to diagnose someone with an opioid use disorder. And there are different ways that we will define it, whether it's mild, moderate, or severe, and that depends on how many criteria the patient has met. There are also non-pharmacological options for opioid addiction treatment. These include things like peer support, motivational interviewing, and contingency management. And as well, we want to address the underlying triggers for use in a holistic way. It's important to note as well that we do have certain programs in place like supervised consumption sites, which can be very helpful for harm reduction. So Insight, which was one of the pioneers in BC, this was a safe supervised injection site where patients were able to obtain clean supplies and inject their substances under medical supervision. And we saw dramatic increases in terms of a 30% increase in detox use by facility users and a 75% change in their patterns of substance use and injection of substances. We also saw really great improvements in terms of safe practices like condom use, for example, showing the benefits of a program like this. And even though it was controversial in its time, it's now been established as a very safe and effective intervention for reducing the harms related to drug use. In terms of treatments, and I'll go through this part quickly in the interest of time, we do use different opioid agonist treatments, and these include methadone and buprenorphine, to essentially replace the illegal or misused opioids with a longer acting, less euphoric one. And what it is it's evidence-based, it reduces withdrawal and cravings, it reduces harms associated with opioid use, and it engages patients in counseling, support, and healthcare. And it also ultimately decreases morbidity and mortality, and it saves lives. And it improves participation in family life, social, and occupational activities. What it definitely isn't is it's not enabling addicts, it's not replacing one opioid with another, it is not doctors being drug dealers, and it is definitely not contributing to the opioid crisis. And certainly we do hear these misconceptions about it, even in the medical field, but this is certainly not the case. The evidence is clear regarding it, and I will just say that we certainly see higher retentions in treatment, less illicit opioid use, reduced risks of infection, overdose and illegal activity, and ultimately better adherence to medication and psychological therapies. Another option apart from methadone is Suboxone, which is a safer alternative, and that's related to its pharmacokinetics. It's a partial opioid agonist, and so it allows people to potentially use Suboxone and have a lower risk of overdose from Suboxone, even if they can currently use other opioids. In addition, it also has naloxone, which is an opioid antagonist in it, and that's really just a deterrent from injection drug use. The naloxone doesn't work if you ingest Suboxone properly orally. But if someone injects Suboxone, then naloxone will actually block the effect and cause someone to experience withdrawal. I'm going to skip over these parts just because it talks a little bit about the pharmacokinetics, but happy to explain it to anyone who's interested. And as I said, there's a lesser overdose effect from Suboxone or buprenorphine compared to methadone because of the fact that it's a partial agonist, so there's a ceiling effect. In terms of other new developments, there is even more emerging in the field. So now we have implants that are available where you can have a continuous release formulation of Suboxone or buprenorphine that's going underneath the skin. And those implants can last for 6 months. So you can give someone a continuous release of the buprenorphine to manage their withdrawal. You give them the implant and they don't have to worry about it for 6 months. So really amazing development. There's also similarly a once monthly injection that can also be used to treat opioid use disorder. And this avoids patients needing to come to see us every week, needing to go to the pharmacies constantly. They can just get their injection once a month or their implant every 6 months. And those are examples of what they look like. In terms of the testimonials that we hear, I'll just read the last one, which is the whole stereotype that surrounds methadone prevents so many people from getting involved. People need to know that methadone is okay and that it works. And if you look at some of these other testimonials here, you'll see that people have been able to get their lives back because of the fact that they're no longer having to use illegal drugs. They have a safer alternative. They don't have to worry about the toxic drug supply. And it's something that's treatable. It's something that's a medical condition, just like blood pressure or diabetes, which I treat all the time as a family doctor. This is like that. It's something that we can give people a therapy for and they can manage it. And it gives them a lot more agency and power back. And lastly, addiction is a health condition, not a criminal one. If there is one thing you can take from my talk today, that would be it. And I want to thank you all for your time today. It's been such a pleasure to speak with you. Thank you.
Wow. Thank you so much for all of that information and also for your ongoing contributions to the addictions treatment sector. Your insight, coupled with your empathic approach, are so critical in our effort to mitigate the opioid crisis. So thank you so much again. I'm going to move us on, and I'm going to introduce our next speaker, and that is Allie Hunter. Allie is an internationally recognized subject matter expert, trainer, consultant, and speaker on the overdose epidemic and recovery-oriented policing. Allie is the executive director of the Police Assisted Addiction and Recovery Initiative, providing training and technical assistance to hundreds of communities to help create non-arrest pathways to treatment and recovery. In the spring of 2017, Allie received a Nonprofit Excellence Award for the Massachusetts Nonprofit Network, and in 2019, Allie was selected for the Social Innovation Forum Social Innovator Accelerator Program. In the fall of 2018, Allie received an AmeriCorps Excellence Award for her groundbreaking Recovery Corps program. She is also a certified instructor of the CCAR Recovery Coach Academy and Recovery Coaching Basics course, and a BSAS Certified Recovery Coach Supervisor. Allie holds a Bachelor in Politics from, I'm not going to say this correctly, but also a Master's in International Development from Ohio University and a certificate in Nonprofit Leadership from Boston University's Questrom School of Business. She's also driven by her lived experience with close family members impacted by addictions. So without further ado, Allie, the floor is yours. Thank you.
Thank you very much for that introduction. Thank you for having me today. I am going to share my screen as well and really pick up where our last presenter left off. So I'm here from the United States, Massachusetts on the East Coast, and I'm here to share a little bit about a movement that was started by police departments in the area, really recognizing that addiction is a disease, not a crime, and we are not going to be able to arrest our way out of this. So what we do as an organization, as I'll go over the next 10-ish minutes, is we try to support police departments to create programs that serve as an entry point for people struggling with addiction, ultimately saving lives and reducing crime, and really contributing to this paradigm shift away from arrest first approaches to addiction and towards more recovery oriented programming. So I guess I'll also share, as my bio said a little bit, this work is really significant to me because I have loved ones that have struggled with addiction, including my younger sister who struggled with opioid addiction for several years and has survived about 13 overdoses before finding recovery. And I think her experience for me definitely highlights just how important it is to have first responders that carry Narcan and that are willing to, be part of someone's recovery journey. And she wouldn't be here without those first responders. So I see firsthand just how difficult it is for people to access treatment, even when they want it, and what a big role police can play in changing how communities address addiction. So I'm happy to be here again from Massachusetts and just sharing a bit about the movement that we've built, and in the hopes that you might be able to join us and start something similar in your communities. So, this is, again, a little bit of a US focus, but there's so many similarities in terms of how this is impacting the US and Canada. Fatal overdoses across the United States are up about 29% over the last year and a half. Of course, this has been exacerbated by COVID-19 and overshadowed by COVID-19, making people more vulnerable than ever. So we actually, a couple of weeks ago, the CDC kind of shared their preliminary data that we, for the first time, had over 100,000 fatal overdoses in the 12-month period that ended in April 2021. So I think that milestone certainly, encourages us to redouble our efforts and think about how to approach this crisis differently. And another really important thing that I always keep in mind, because we work with law enforcement, we're able to see some of their local data more real time. And what we've found is that there's about 9 non-fatal overdoses for every 1 fatal overdose. So just imagine what that number would look like if it weren't for, the ability to revive a an overdose with Narcan. But the first bullet point, I think, is really one of the key things that we're looking to address here. The idea that 89% of people who have a substance use disorder don't have access to treatment. And this is a gap that, is quite significant, and law enforcement can be part of addressing that. So why police? This is certainly something that feels like a public health issue, and but in many ways, police are closest to the problem. They interact with individuals who use drugs, whether it's through 911 calls for service related to addiction, or different, opioid reversals, overdose reversals. They're closest to this population. So I think that gives them access and that front row seat to be able to be part of the solution. Also, police are natural problem solvers, looking for more tools in the toolkit. And for many of them, their training didn't involve how to help people connect to the services that were really underlying the criminal behavior. So this problem solver dynamic is really helpful because police are looking for the right tools to address the issues that they're responding to in the community. And then the number one reason that people become police officers is to help others. So kind of tapping into that is something that these programs and these approaches can help do. And again, ultimately saving lives and reducing crime. So again, PARI's model, Police Assisted Addiction and Recovery Initiative, we're really trying to recognize that arrest and incarceration for an individual who is struggling with a substance use disorder is really just going to be a revolving door that's expensive and time consuming and ultimately not effective, especially, the definition of addiction being that people continue use despite negative consequences. So it's not the type of thing where a negative consequence is typically going to motivate someone to begin their recovery. So really looking to give police the ability to connect people to treatment and recovery, which has better outcomes in terms of community safety and well-being. So PARI, again, recognizing that police have this front row seat in the community. We're a nonprofit organization, and we really try to help form public health, public safety partnerships. By doing so, departments are saving lives, reducing crime, keeping people out of the criminal justice system, and ultimately improving their communities. So we work with about 700 law enforcement partners in 40 states and a couple in Canada. I'll show you the map in a couple slides. This has absolutely been a growing movement. We've only been in existence for about 6 years, and we've just been on a growth trajectory that entire time, because I think there is this universal recognition that police are not going to arrest their way out of this, but at the same time, looking for guidance and support on what to do differently. So that's kind of where PARI comes in, where if a department is interested in approaching addiction differently, we give them the tools and the training on how to do that. So we were started in a small town called Gloucester, Massachusetts. It's known as a fishing town. And there was a series of fatal overdoses in 2015. And what the chief at the time and the mayor at the time decided to do was establish their police station as a safe station where anyone could walk in 24 hours a day, 7 days a week, and receive an immediate referral to treatment. Pretty simple concept, but also pretty significant in terms of shifting the role of police in the community. And, the police department being one of the few places that's open 24/7, this just created a new, a location for people to seek services. One component of the program was also that people could turn in drugs or paraphernalia without fear of arrest, which, to be honest, was not very commonly done, but it did help kind of reframe the role of police and build trust so that people really could see law enforcement as helping them, as opposed to this being some type of a way to have some type of punitive action. So it really shaped kind of community trust in the program. We started the program with volunteers that were called angels, but it evolved into more of a team-based approach. And now they have a full-time recovery coach and designated officers who really head up the initiative. So the goal, quite simply, was to prevent overdose deaths and to create this simple entry point to treatment when the individual was ready, when they were at that kind of stage of change, when they were in action mode. I know from personal experience, there were so many times with my sister where she was interested in treatment and would make some calls or show up to a crisis center, but didn't have a ride, or there wasn't a bed available, or something happened and that window of opportunity closed. So what this is really trying to do is create that entry point so treatment is more accessible when individuals are ready. And it shifted kind of the role of the police department away from this enforcement style response to addiction to more of this helping and partnering kind of a role. Again, program components were changed over time. They added new program elements and, approached this in a much more holistic way. To be honest, when they started, they were really just thinking about, okay, what I'm doing here is I'm getting people into detox. And now it's really evolved into helping people to support their basic needs, get connected to housing and employment, supporting family members, doing community events. And so it's a much more comprehensive program as opposed to just a simple entry point into detox. We had a letter, I will clarify too, this is a letter that was published at that New England Journal of Medicine based on a research project that the Boston University School of Public Health did on the first year of the Gloucester project. And essentially what it showed is that the department was effective at getting people into treatment, and that participants shared that they were treated more positively at the station than in their past attempts seeking services. So it's kind of simultaneously calling out that there's work to be done in the healthcare system, and also that police, when trained and when they have this kind of mindset shift, can be very effective at getting people into treatment. So that's just the letter. So from that, the program caught national attention, and it sparked this interest with departments that were recognizing that what they were doing was not working, but they didn't know what else to do. So PARI was created as a nonprofit organization to try to provide that training and technical assistance to help departments either replicate that program model or to start a program that was kind of appropriate for their community. So we're headquartered in Boston. I'm actually sitting in a station in Lynn, Massachusetts, just a little bit north of Boston, where we just did a training and convening on one of our projects. But any police department can join, totally free to join. This is our map that I mentioned. As you could imagine, where we started in New England, we have quite a few partners. We have a ton of partners in the kind of Michigan area, Illinois, and then other parts of the country, I think, are still kind of learning about what we do and how we support departments. We have just a couple partners in Canada, but perhaps there'll be some interest after today's call. That would be wonderful. So there's 4 primary program models. The first one, self-referral, is really the model that they had in Gloucester. The other 3 models are based on the concept of outreach, either outreach following an incident, like a non-fatal overdose, outreach based on risk and identification of an individual who might be at risk for overdosing, or officer referral, which is the idea that any officer at any point during patrol or in general, any encounter with someone struggling with substance use disorder is an opportunity. And so with the right training, the right tools, they'll be able to connect people to treatment and services as just part of what it means to be a police officer. So when we work with a new department or new community, we really tailor the program to fit them. It's not a one-size-fits-all thing. They could take components of multiple program models and adjust them. But really the idea is that we're trying to work with people at the community level in a non-coercive way. So these are all based on voluntary engagement with law enforcement. It's not a kind of diversion program where if you say, no, thanks, I'm not interested in a referral to treatment, you'd get arrested. That's not really the idea. The idea is that police are able to connect with people on a voluntary, non-coercive basis at the points of contact that they already have and facilitate those referrals. But one key theme is definitely that the programs continue to adapt and evolve over time. And this is still a relatively new field. So there's a ton of innovation still happening. And we're still kind of like building the evidence base of which program components are most effective at saving lives and reducing crime. So I kind of shared a little bit of this already, but just the idea that, most departments, their motivation for joining PARI and starting a program is to save lives. In some cases, it's also to reduce crime, or they might be looking to address a specific issue like homelessness in their community and how that co-occurs with substance use disorder. It's diverting people away from the criminal justice system, improving trust and collaboration, and ultimately is more cost effective. So PARI does a bunch of training and technical assistance, whether it's a 2-hour training or a 30-hour training. We have resources online, lots of different templates and examples, so you don't have to start from scratch. We do a national summit. We have a program that was mentioned in my bio where we place service members into police departments as recovery coaches and as program coordinators. So there's a lot of different ways that we can help departments. There was a recent publication in the International Journal of Drug Policy with these 5 kind of key themes. I think the couple that I'll point out, one is just how critical partnerships are. 2 is how critical high-level leadership is. So essentially the chief of police having some buy-in. And then the 5th bullet point that I think is interesting is that these programs contribute to a shift in beliefs about substance use disorder among police officers. So when they start implementing a program, they might feel differently than how they feel over time through implementing the program. So takeaways, I'd love for you guys to check out our resources and materials and think about if you'd like to bring this to your community, either because you don't have any programming happening right now, or perhaps it could enhance whatever you are doing already. Or if you have the most amazing program out there, I'd love to learn from you so that we can bring that to our other partners as well. But I will wrap there to hand it off to our next presenter. Thank you very much.
Sorry, I was having trouble getting my video camera back on. Thank you so much, Allie, for your presentation. That was phenomenal, and certainly I really appreciated how your program or your model leveraged the strengths of the police force, specifically around their problem-solving abilities and their strong desire to help others. I thought that was really innovative in addressing the opioid crisis head-on. So certainly, I think that you've certainly given us a lot of food for thought. And my wheels are turning, and I'm thinking about how do we replicate a model similar in sort of our region, and I'm sure others are thinking the same. So thank you so much. I did notice that there was a question, and I'm just going to hold it down until our next presenter has had an opportunity to present, and then we'll go back to those questions. So last but certainly not least, we have Haley Hrymak. Haley is a lawyer with Rise Women's Legal Center in Vancouver. Prior to working with Rise, Haley worked with the Federal Crown in Winnipeg and in Vancouver. She holds a Master of Law from the University of British Columbia, and her findings are published in the Dalhousie Law Journal and the Manitoba Criminal Law Journal. She's currently a PhD student at the University of British Columbia, where she's conducting research on family violence and the family law system. Haley is also has a consulting practice where she assists with designing and conducting thoughtful research that advances systemic change. So, Haley, the floor is yours.
Okay, thank you so much. Is everyone able to see my slides and hear me okay? Thanks. Okay, great. Well, it's such a pleasure to be here. And I'm going to be talking today about some of my findings from my master's research on how the criminal justice system has responded to street level trafficking. And as Mary has introduced me as, my background is I worked with the Federal Crown in both Manitoba, in Winnipeg, and in Vancouver between 2015 and 2019. And also I have done research on the criminal justice system's response to street level trafficking. So what we know is the way the criminal justice system has responded sort of as a textbook, besides from the innovative programs that focus on rehabilitation, is really once the crisis started, there's been an emphasis on deterrence. And the idea behind that is that courts are trying to send a message that trafficking in fentanyl will lead to a serious sentence, which ultimately leads to longer jail terms. And that's despite that many people who traffic at the street level, or another way of saying that is at a low level, are themselves people who are using substances and are often trafficking as a survival technique in terms of being able to get substances themselves. And one study found 40 to 50% of people using drugs in that study were also selling drugs. So this idea of sending a message that if you traffic in this strong substance, you're going to end in having a really serious penalty, which is this long jail term, is actually being implemented on the very people that are also most at risk of overdose and are the ones using fentanyl themselves. And what happens in the criminal justice system is that people who end up before it are the ones that are more easily detected by and large. So while police are doing innovative and elaborate long-term investigations for wiretaps and trying to get at people dealing and importing in higher quantities, what is often very common is for people to come before the courts who are dealing at these low levels because they're easily detected. So when people enter into prison, it's a very dangerous time for them because they're potentially not able to use, or they're going through a period of abstinence, depending on where they're incarcerated, or if they're going to be going for bail or those types of things. So they're then, when they're released, because they don't have the tolerance, because they haven't been using in the same way they were before they were incarcerated, they're facing a 3 to 8-fold increase of overdose within the first 2 weeks upon release. So there's been a lot of conversation today in earlier presentations as well about the harms of prisons and being removed from your community, your supports, your housing, any sort of employment. And what we know about prisons is that they're potentially, not necessarily helpful in rehabilitation because they're designed to be punitive. But further to that, when you take someone in mind who's been using fentanyl, they're also potentially at this increase of overdose death after being incarcerated. And really, as has been talked about by Dr. Damji as well, research shows that laws and policies surrounding drug use have a negative effect on the health of people living with addiction, and yet it's estimated that 56 to 90% of people who inject drugs will be incarcerated at some stage of their life. So I can't say it better than Michael Jackson, so I'll read his quote here. "Society has spent millions of dollars over the years to create and maintain the proven failures of prisons. Incarceration has failed its two essential purposes: correcting the offender and providing permanent protection to society." What should be implemented, and what many people here I know are a part of, is evidence-based harm reduction responses. So criminal justice system should be led by what's already existing evidence-based harm reduction responses. So for example, the Insight and other supervised injection sites, as well as projects like the Naomi Project, where people who use substances were provided with medical grade heroin, diacetyl morphine 2 to 3 times a day. And it took out the criminalized aspect of using drugs, and they were able to focus on other aspects of their lives instead of constantly trying to access drugs. And it had overall hugely positive impact in their life and no negative impact in the surrounding community. Expansion of community supports and diversion programs, as well as every response should be meaningfully informed by people who are using substances, recognizing they're the real experts. They'll know what policies will work and will be effective, and they should of course be paid for their time, and consideration should be put to them on how they want to be incorporated into meaningful sort of evaluations of proposals. So there are alternative measures that I think a lot of people who are attending today are maybe a part of those, or have these innovative programs that are based in harm reduction. But just overall, the criminal justice system and sort of the letter of sentencing principles aren't necessarily rooted within that. And certainly the response for fentanyl trafficking hasn't been rooted in that. And that's one reason for that is, as many people experience potentially in your work, there's scarce availability for alternative measures. So drug treatment courts, which are often very effective and have really positive results, particularly for the people within them, are very limited. So there's only one, for example, in the province of BC. Also, there's a lot of reasons people can't get into these types of diversion programs and alternative programs. Whereas you never hear in court judges and lawyers talking about, we can't send this person to jail because there's no space, but you hear that all the time for rehabilitation options. And included within this is that, there's a lot of research surrounding the connection with safe housing and having treatment opportunities as alternatives. So while substance use can lead to harms to individuals and families, many of these harms really derive from the problematic public policies and structural inequity. And most people who use drugs do so without significant harms to themselves or others. And this is sort of detached from the toxic supply issue. If people were given a safe supply, the real harm is actually within the criminalization of the behavior of drug use. So drug criminalization has also amplified structural inequities in Canada, and these have contributed to First Nations, Inuit, Métis, and Black people being disproportionately and negatively impacted by much higher rates of criminal prosecution and incarceration. So when we talk about having these longer prison sentences, we know that they're actually impacting the people who systemically are already having longer periods of time in custody. There's a big need for decriminalization. I know we're maybe a bit a ways from that particularly when we talk about street level trafficking, but we're getting steps closer when we talk about simple possession, more so in practice than necessarily the actual legislation. But illicit drug overdoses are caused by this toxic supply. People aren't able to have control over what substance they're using because it's an illegal market, and people need access to the safe drug supply. One study found that 1 in 8 Canadians have a close friend or family member who's become dependent on opioids. So just to say, it's such a pervasive problem. I want to end on one positive. So earlier this month, there was a decision from the BC Provincial Court in Campbell River, and the judge concluded that people with addictions who sell small quantities of drugs at the street level for the primary purpose of ensuring their own drug supply are far less morally culpable than those farther up the hierarchy. And that case relied on expert evidence from Ryan McNeil, who's a professor at Yale and the director of harm reduction research there. And he came to testify about the harms of prison sentences. So for anyone practicing and taking case law to court, this is a really interesting case. And the judge ultimately found we're in a really different time right now. This isn't 2015 where fentanyl was rare and we were trying to deter and make sure that people knew that they had to be really cautious about selling this. This is really a time where the research shows that fentanyl is in a lot of the substances, and it's hard to even just get heroin, or and many substances are actually contaminated. So this whole piece of trying to deter and send this strong message is really detached from the reality that 90% of illicit opioids are containing fentanyl. So a few things to consider, because I also recognize that the main recommendation of decriminalization isn't necessarily helpful to our day-to-day work in the criminal justice system. I was thinking, one piece of information you could take on how to sort of incorporate the information from today and from throughout the conference is to sort of take a 30-minute window in your calendar next week and just reflect on your own practices. I know many people here, you're leaders in harm reduction practices in your own work, and you have incredibly innovative programming, and you're coming at sort of these issues from all different angles and lenses. But to think of what ways could you further incorporate harm reduction practices into your work, and is there something from today that you could potentially share with your staff in an email or in a meeting? Because a lot of these really groundbreaking advancements in the criminal justice system, or the big case, for example, of Insight or drug treatment courts, when they first started, they really just start as these ideas and they blossom into these huge, programs that then have countrywide effects. And while the criminal justice system sort of has this harmful, punitive approach that is going to take a while possibly to break down, particularly for more serious offenses, those individual actions that actors within the criminal justice system, from sheriffs, probation officers, lawyers, judges, social workers, counselors, people working with people in the justice system, those will have huge impacts on people's lives and safety. So thank you so much. I have my contact information here. I'm happy to talk beyond that, but I'll stop for now because I think I'm out of time.
Thank you so much, Haley. Your research is so insightful, and certainly it causes us to stop and think about our own work and what we do, how we proceed with folks who are involved in the justice system. And I really appreciated your last remarks around that, taking the time to self-reflect, not only for your own growth, but also to let certain ideas and innovations sort of percolate and potentially seed and grow. And to your point, from treatment courts and all of those other innovative ideas, they started with an idea, and look how they've grown, and look how they're having a positive impact on those who interact in the justice system. So we certainly do really appreciate the research that you do, and hope that the system can benefit from that research. And we know that evidence-based harm reduction is key in working with this opioid crisis. So thank you again. I'm going to move us. I do appreciate that we are running short on time, but there was a question that I saw in the Q&A, and I just wanted to bring this one up. So Allie, this was, I think it was directed to you, but I can leave it kind of open. Haley and Dr. Damji, you might have some insights as well, but the question was really around, in your observations, how have you noticed sort of police shifting their perspectives or shifting their practices in order to gain sort of the trust and respect amongst marginalized populations where they may not have had those good interactions before?
Yeah, I mean, I can start maybe just give a couple examples. I think one of the most significant things that we've done to help with that culture change is embedding people with lived experience who are in recovery into police departments as recovery coaches. And the power of having someone with lived experience co-responding and working alongside law enforcement, I think, does a lot to help with this kind of organic shift, one officer at a time, of how they think about addiction, and having someone that they trust and have a rapport with, and being able to ask questions and learn from someone's lived experience, and also just see the positive side of recovery being possible. I think a lot of police, they see the negative side of addiction, they see the criminality, they see the overdoses, and they don't necessarily get to see people thriving in recovery. And so having the opportunity to see the success stories, showing them that recovery is possible, that the work that they're doing matters, I think goes a long way. Also, a lot of the training, like the first part of the presentation, a lot of the training that we do just around understanding addiction and kind of shifting it away from being seen as a moral failing or a crime or a choice, and understanding the way it affects the brain, and even things like social determinants and adverse childhood experiences. Like, police are not trained on that type of thing. And so having a non-judgmental learning environment where they can learn those things, I think is all contributing towards culture change. But in my experience, police are really motivated by the idea of saving lives. So when I see police embracing things like harm reduction and all these other kind of innovative things that 10 years ago no one was doing, it's truly their heart is trying to save lives, is what I've kind of experienced.
Thank you so much, Allie. And to Dr. Damji and to Haley, in the work that you do, how are you seeing a shift amongst your colleagues?
So maybe I can start from the medical perspective. So certainly I've seen a shift in terms of my colleagues kind of better appreciating harm reduction. I do recall there was a time where the idea of having patients or clients who use substances coming into a medical facility, administering, potentially contaminated heroin that has fentanyl on site, on premises, and providing them with needles and coaching and, advice in terms of safer ways to inject would have been completely ludicrous and unacceptable in the medical community. And even when I went to visit Insights when I was a medical student, that sentiment was still quite prevalent in terms of this being something very experimental experimental and a bit out there. I would say I've noticed since being in practice now, and I started my practice in 2019, it seems as though the acceptance of these types of models has shifted, and we see evidence and really hard evidence that they are effective evidence-based treatments that do save lives. Is it perfect? No, in terms of, the profession, and certainly there are people that still carry those views, and that could be very challenging for the clients and patients who are living with substance use. But I'm hoping that as we continue to build more and more mass around this, more and more advocacy around it, as we see, our medical officers of health in Toronto, for example, coming out and saying that we need to decriminalize possession of substances, I'm hoping that also will translate into our medical profession more broadly, but there's a lot of work still to be done.
And I can just add that one of my papers was published just last year in 2020, and I'm delighted to say that many of my recommendations are sort of old now, and that it's old research, and people have, it's been incorporated in various ways. So things like red zones where people weren't allowed to be released to certain areas, and these conditions like not being able to use or abstain conditions, and not being able to carry harm reduction supplies, so not being able to have any drug paraphernalia. Those conditions, are now sort of accepted to be just a way of penalizing people who use substances, as well as the conversation surrounding decriminalization has expanded in such a huge way, where chief of police in many departments have sort of called for the decriminalization of simple possession. And we know that while it's maybe not the letter of the law as of now, it's really the practice in many urban centers that to take this harm reduction approach at the policing level. And I mean, this case that I shared in my last slide, RV Ellis, we'll enjoy it while we can, because I think it might be appealed within the month, but it's just a huge step towards a judge and an expert and everyone sort of coming together in this decision to say that prison isn't what is appropriate in this situation, whereas that's really what has been in that exact scenario, just sort of expected up until now.
Amazing. Thank you all so much. And we have just one more question. They're very similar, so I'm just going to throw them out there just because we do have a couple minutes if you all are still free. So the one individual indicated, for me, I work in residential facility attached and funded by hospital, so it's very medical model based and led. And I am totally lost for how harm reduction approach can be incorporated. I am very inquisitive and open-minded. Any ideas or suggestions? And then that's a follow-up to another individual who agreed, who also works in primary care, the front line, and they want to know more about how they can incorporate harm reduction into their jobs. So whoever wants to answer that.
I can start with it. Sorry, Allie, I'll say something super quick, but just to say, I see Allie's comment, which is open-mindedness, which I was just going to add. Sometimes, everyone is trying to do their job well, and there's lots of rules in order to do that. And those rules maybe are completely contrary to what you actually want to implement for a harm reduction evidence-based approach. But having this open-mindedness piece, and really every one of your interactions sort of being rooted in meeting people where they're at, that's one of the fundamental pieces of harm reduction. So while maybe the policies and rules of your actual workplace don't foster that, you as an individual, I know it's very hard, but that's just one sort of piece that you can control, is how you interact with people.
Yeah, and thank you. I'll maybe just add, so a big part of what we're doing is helping law enforcement be open-minded to harm reduction. And in many ways, I feel like we're hiding harm reduction within engagement. So we're calling it, oh, these are fentanyl test strips to help you engage with people. And, this is recovery coaching and motivational interviewing to help you engage with people. So we're kind of like packaging it slightly differently so that it's a bit more palatable. And I see that as like us meeting our law enforcement partners where they're at and figuring out, okay, what are the components that they're open-minded to, and just kind of take it step by step. We don't need to force them to do something that they're not quite comfortable with, but there are things that we can agree on. And I put in the chat a little bit that in the last 18 months in particular, I've seen a lot more open-mindedness towards things like fentanyl test strips, because I think it's just a byproduct of the pandemic, people are just kind of a little bit more willing to think outside the box and a little bit more willing to just kind of go for it, as opposed to spending 6 months planning and discussing. It's just sort of like, let's just try it. So I think that this is a moment to be potentially, doing these pilots or innovations, and you can sort of reframe it or message it in a way that doesn't feel quite as, I don't know, controversial as it could be felt to others.
Yeah, and working in the health system as well, I would echo all that's been said as well. I think that there's such a ripe opportunity for innovation right now. And the other thing I would just add on to it is just not to go at it alone. I think that from my experience working in leadership in the health system, if you can build, a coalition of people, use opportunities like this conference today to connect with others in your region, or even just around the table here today, and bring that forward, because it's one thing if you're one person in a large institution trying to advocate for change, and certainly that's possible, but it's much more effective if you're able to mobilize additional clinicians from other departments, members of the community who are concerned. If it's part of a hospital, maybe getting members of the hospital board involved, and just kind of being around those tables and seeing that with some of the other hats I wear. I think the most successful, radical, even though it's not really radical, as we all know, this is really evidence-based stuff, but radical to potentially other people around that table. It's helpful if you bring other people that they know and respect to join you in that. And the nice thing is we have data now. Before, we were dealing in a vacuum where a lot of this stuff was theoretical. And even though it was on the nose in terms of it actually being correct, we didn't have a lot of data to back it up. That's a very different reality now. We have data from Insights showing the benefits of harm reduction. We have documents from public health, that show the evidence around these interventions. So definitely use that to your advantage and don't go at it alone.
Absolutely. I agree with all three of you. And I think it's important as well that, that is why His Honor created this committee. That is why we're having this annual conference right now. We have to be able to engage in these conversations, educate each other, partner up, and work together to make the changes that we want to see. Well, it might feel very overbearing and difficult being one person in a big environment, trying to advocate for change. That's why we're here. That's why we're doing these things. So thank you to all three of you very much. Very insightful, very helpful. A great way to finish off day one of the conference. So thank you very much.
Thank you for having us.
Thank you.
Bye. Okay, everyone. So that is day one of our conference for today. I hope everyone really enjoyed the content. Just keeping in mind, we do have another 2 days ahead of us. If you have not yet registered for those, you can go to our website, which is justicetreatment.org, and you can register for the next 2 days. Just a couple reminders, our recording will be available in about 7 to 10 business days once we have completed the entire conference. And if anyone has any questions or concerns, you can always feel free to reach out to His Honor or myself. And we are very glad that you came today. So everyone take good care, have a nice evening, and we hope to see you tomorrow.